Hi, I'd like to cover a few things about ECMO, extracorporeal membrane oxygenation. First section here will just be sort of a general discussion about the system components, but then in later talks I want to talk about VA ECMO and VV ECMO and some of their particularities. So I'll draw a patient here really quickly and then describe the basic core elements of an ECMO circuit. So first off is a drainage cannula of unoxygenated blood. And so typically that's via the femoral vein, but at actually the end of the catheters in the intrahepatic IVC. And then you have to return blood somehow once it's been oxygenated. And so classic VA ECMO, that will be in the femoral artery. And in VV ECMO, that will be in the right internal jugular vein. So we'll assume we have just peripheral fem-fem cannulation here. So when the deoxygenated blood encounters the ECMO machine, it's going to encounter a pump which has a certain flow rate that you can control. Typically, we look for flow rates between 20 to 50 mils per kilogram for your patient in order to replicate the action of the heart. The blood that is flowing through the circuit then is pumped into an oxygenator. And then, once oxygenated, that will be returned to the patient. And so, things that you have control over are the flow rate to a certain degree. I mean, you have your hands on a knob that you can control it, but really that's going to be dictated by venous return, just as cardiac output in the normal body is dictated by how much can get back to the heart. Other components you have control over are what's known as the FDO2, which is derived by blending air and oxygen from external sources into a blender and then push through the membrane oxygenator at a certain sweep speed. And then finally there's a heating component that can keep this at a pretty constant temperature. So where you set these different devices at will depend on what your patient's needs are. So for example, somebody who is on VA ECMO, which is essentially cardiopulmonary bypass, that would be a patient who has a dysfunctional heart plus or minus dysfunctional lungs. So if your lungs are bad and your heart's bad, VA ECMO will work fine. If your heart's bad and your lungs are okay, you still need to be on VA ECMO. And so your flow rate and what you're going to try to push through the system is essentially going to be dictated by what you perceive the body's need for DO2 is, which is depending on the metabolic rate, and you want to exceed what the patient's metabolic rate is by a couple-fold. And so markers of perfusion such as lactic acidosis, oxygen saturation, pH, organ function, general appearance, warmth, those will all be handled by trying to get the flow rate to be commensurate with what the body's demanding. Sometimes the venous drainage system is not adequate to meet that need, and so extra drains are needed. In this case, this would be an example of VV-A ECMO, where once you had VA ECMO, but now you have two venous drainages. So a quick note on nomenclature, if you have like a two-letter designation, your first letter is where the blood is coming from, the second one is where it's going. When you have a dash, this is where the blood's coming from, this is where it's going. Okay, moving on. So what would make you want to change your FDO2? Well, if you've got bad lungs, typically you're going to go for a high FDO2 of 100%. This is analogous to FiO2. Typically and that would be on VV ECMO. For VA ECMO, typically we just set it at 100% and just give the body oxygen-rich blood. Sweep rate, though, that's how you're going to eliminate CO2, and so that dictates CO2 concentrations. So you're looking for normal carbia. So a typical starting setting would be, say, 5 liters per minute. You get a blood gas and see what your PaCO2 is and alter this accordingly. In cases where you're trying to blunt the respiratory drive, you can often take that away by having a slightly lower CO2, say a PaCO2 of like 30 or so rather than 40. And that can actually help you achieve some of your therapeutic. Okay, so given all this control that you have over the system, how do you analyze it once it's set up? Well, most important thing is don't ignore the patient. So whatever the patient's telling you is right. And so you're going to be looking for indices of perfusion of the patient. Things like lactate, things like pH, things like warmth, organ dysfunction, etc. Secondly, you're going to be looking at oxygen saturation. You want to make sure that what you're delivering to the body is getting there. And so you're going to get an ABG from the right arm somewhere. Reason being is that is the most proximal blood vessel. And so if this arterial oxygenated blood is making its way up to the arch and perfusing the brain, if the first stop along the way checks out, meaning the right arm, then chances are you're getting really good flow or properly oxygenated blood to the head vessels. Definitely want to have something like cerebral oximetry on and monitor urine output and a number of metabolic parameters as well as organ-specific parameters, things like lipase, liver enzymes, renal function enzymes. Okay, but as far as the circuit itself, there are a few other things that you can measure. One is what's known as P vein, and that's the pressure within this line, and it's always going to be negative. It's going to be something like 70 to 80 negative, and certainly becomes problematic when it is less than negative 100 or more. And so that means basically that you're sucking pretty hard from your motor and you're not really yielding blood. You're encountering resistance at the other end of your cannula. So that could mean that the cannula is not properly positioned. It could mean that you're just out of blood, you're bleeding, you're hypovolemic, or that you have unusually high pressures in your abdomen and thorax, or the patient's fighting you in some way. So that's one way of measuring, monitoring venous return, is just kind of like the pressure differential between the patient and the pump itself. And then the pump will deliver blood to the oxygenator at a certain pressure, and there'll be a pressure drop and it'll leave at a certain pressure. And comparing these two, called delta P, also tells you a little bit about what kind of resistance you're encountering in your oxygenator. And so you don't expect much delta P early on in a run, but say a week or so into someone being on ECMO, this might actually increase. And so like normal values are 20 to 25, even less. But when they start to get to the 30 plus range and they continue to climb, that could indicate that there's fibrin and other kinds of sludging that just might be aging this oxygenator a little too much. The other thing that can kind of triangulate in on that same story is actually what is the PaO2 of the gas leaving the oxygenator. And so when an oxygenator is brand new, it's going to be something in the 400s. And so again, if you're starting to get lower values of PaO2, and that's in the context of also delta P's going up, then you're going to look pretty hard to make sure there's not some clots in there, and you're going to have to seriously consider whether that oxygenator is going to last. You might have to intensify your anticoagulation, but a lot of times it just means that there's this deposit of stuff that really isn't clot per se, but just junk that's just causing things to be very sluggish. LDH levels measure daily also can give you a little bit of sense about whether there's some kind of hemolysis or damage that's occurring. And as your delta P's go up and your resistance goes up, so might your hemolysis. So let's talk about a couple things that you get called to the bedside for and some of the bigger problems that can develop. So one term to cover is what's called chugging, and that's a rhythmic movement of the venous drainage tubing. And it's caused by very rapid emptying of the right atrium and flow into the tube. And then when the atrium is empty, the tube can no longer fill up. And so there's this cessation of flow that just causes it to kind of hit the brakes and shake. And so while it's not being filled, blood is reaccumulating. And so then you'll get kind of a refill, no fill cycle. And that flow that happens intermittently causes the tubing to shake as it heads toward the pump. And so, as you might guess, that is typically associated with decrease in the value of the P veins during these events. And you also might get a low flow situation. In fact, that's probably the other thing that would get you called to the bedside is low flow alarms associated with chugging and decreased P veins. And so all that signifies is just problems either from hypovolemia, from bleeding, or some mechanical obstruction to venous return. And so that's what it's your job to figure out. And it could be a number of different things. So I'll list some of them here. One is this bleeding, hypovolemia, inflammatory processes that can cause the redistribution of blood flow throughout the body. And then there's some mechanical events such as agitation and patient movement that can just change the dynamics within the chest, the abdomen, and the venous drainage system, as well as catastrophic increases in interthoracic pressure, interabdominal pressure. So things like tension pneumothorax, ventilator dysynchrony, or say following an abdominal procedure, pneumoperitoneum. And then finally, the cannula can be misplaced. And this could be something that's been kind of like chronic and not noticed from before, that's just been exacerbated by any of these factors here, or it could be just due to the fact that somebody tripped and fell and pulled the catheter out and no longer is it in the right spot. So the right spot is in the intrahepatic IVC, and the liver kind of stents it open. It's a pretty kind of more of like a pipeline like vessel than something that's collapsible, which is ideal for a cannula position. So migration either too far or too shallow from that position can cause problems with venous drainage, and so that's something that you have to look at. So is there a systematic approach to all this? Well, the first thing that you probably end up doing is just turn down the pump flows and see if you can create some steady state where there aren't tons of alarms and pandemonium, and by having less fluctuation in the P veins, there's probably going to be less shear stresses applied to the blood and less likelihood for hemolysis. In the meantime, if there's a plausible story that it's bleeding or hypovolemia, you're going to start giving volume, you're going to take a look at the hematocrit, and you're going to make sure that there's not a bleeding event. And if so, you're going to try to achieve source control. The sources can be a little bit elusive. Anything you've touched in an ECMO patient can bleed, and even days after you've touched it. It's really strange. These patients have pretty normal in vitro parameters of coagulation, be it TEG, INR, platelets, etc. But just as a whole organism, they're out of whack and can bleed pretty much anywhere. It's really kind of a daunting task. So if it looks like it's bleeding, obviously you also are going to stop your heparin, but make sure that your flows are such that you can support the circuit without clotting it off without anticoagulation. So, these are the big ones that you'll be taking care of. And a lot of times it's just a matter of turning the flows down, giving a little bit of albumin or Normosul back, and then just trying to achieve the steady state. But there can be some other things too that require that in the catheter position, that require some ultrasound and radiographic studies as well. And so if you're not really sure what's going on, you have to cast a very wide net and make sure nothing big and bad is out there burning you. Agitation and patient movement can be a little bit crazy. Obviously, we desire our patients to be awake and interactive, but sometimes that's just impossible. Just sometimes them having a higher metabolic rate when being active, just random movements can just create huge problems with the flows. And draconian as it is, sometimes we just have to sedate these people really, really deeply and even paralyze them just to be able to create an upper hand and let the machine do, keep the body afloat while the rest of the parts are healing. So I think these are some pretty generic items that are germane to any kind of ECMO system, whether it's a VA, VV, or one of the hybrid systems. These are just problems that permeate the whole technology and the whole interaction between machine and patients. There's definitely some particulars of VA and VV that deserve some attention on their own, and those will be covered in separate modules. Thanks.